Hello everyone and welcome to our channel MedStudy. Today in this video we are going to see about surgical examination of an inguinal swelling. So let's get started. Here it shows normal anatomy. Here it shows inguinal hernia into the scrotum, and here it shows inguinal hernia into the canal. So now coming to inspection. We have to inspect for side, whether it is right sided or left sided inguinal hernia. We have to look for the position and extent of the swelling. We have to look whether it involves only inguinal region or inguinoscrotal region. Then we have to look for the size. Better tell dimension in centimeters than comparing it with other objects. We have to inspect the shape. Pyriform shape is seen in indirect inguinal hernia and globular shape is seen in direct inguinal hernia. Expansile impulse on cuff over the swelling has to be noted. Then we have to inspect the skin over swelling for any scar, engorged veins and pigmentation. We have to look for any visible peristalsis over the swelling. We have to look for the position of penis as in any deviation. We have to look testes for swelling separate from the testes or all around it. Now coming to palpation. In palpation, we have to look for temperature and tenderness. We have to see whether we can get above the swelling or not. It is not possible in inguinoscrotal swelling. We have to palpate position and extent of the swelling. We have to look for the size, shape, margin and surface. Consistency of swelling, it is soft and elastic in intestine, and duffy consistency is seen when it involves omentum. We have to palpate for relation to the pubic tubercle. It is above and medially in inguinal hernia and below and laterally in femoral hernia. We have to palpate relation of swelling to testes, whether it can be felt as a separate from swelling or not. Now coming to reducibility, whether it is spontaneously reducible or manually reducible. Which part is easy to reduce? If first part is easy to reduce, it is omentocele, and if the last part is easy to reduce, it is enterocele. Finger invagination test. We have to feel the superficial inguinal ring, whether it is patulous or not. Finger in the inguinal ring with nail pointing towards the roof. If the cuff impulse is felt on pulp, it is direct inguinal hernia, and if it is felt on tip, it is indirect inguinal hernia. Deep ring occlusion test. We have to reduce the swelling, occlude the deep inguinal ring by thumb, and then we have to ask the patient to cuff. It is positive, that is no impulse or hernial bulge as in indirect hernia, and it is negative as in expansile impulse and hernial bulge medial to the occluded deep ring as in direct inguinal hernia. Zeimen's technique, it involves index finger over the deep inguinal ring, half inch above the mid-inguinal point, middle finger over the superficial inguinal ring, and ring finger over the femoral ring, that is 4 centimeters below and lateral to the pubic tubercle. This image shows Zeimen's technique. Now coming to percussion. If resonant note is there, it is enterocele, and in case of dull note, it is omentocele. Now coming to auscultation. If the vowel sounds are heard over the swelling, it is enterocele. Additional points, we have to do per-rectal examination to rule out benign prostatic hyperplasia, chest examination to look for the causes of chronic cough, and in case of child, we have to do Cornell's test where the child is held from back by both the hands, abdomen is pressed and child is lifted up. This increases the abdominal pressure and the hernia is more prominent. So that was all about the inguinal swelling examination. I hope you liked the video. Please do like, share and subscribe to our channel. Thank you.